Good afternoon and welcome to our Learn and Share conference call. I'm Russ Derry, and the Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for today is assessing and addressing cognitive function in epilepsy. And we're pleased to have as our speakers Dr. Evan Tank, an epileptologist at Spectrum Health, and Dr. Velisa Johnson, a pediatric neuropsychologist from Helen DeVos Children's Hospital. Thank you both for joining us today.
Thank you for inviting me.
Yeah. So could each of you briefly introduce yourself, talk a little bit about your clinical and research interests, and describe your experience with this topic? Dr. Tank, do you want to go first?
Sure, yeah. So my job duties are almost entirely clinical, and I very much enjoy the challenge of working with patients, particularly with medically refractory epilepsy, any epilepsy, but patients with medically refractory epilepsy in particular present a lot of additional challenges on top of just the standard challenges of epilepsy. So that's something that I very much like. In terms of my research interests, I do a little bit of research in looking at kind of quality of life measures and things as they relate to epilepsy patients in that manner. And this particular topic is very much of interest to me, something that I see every day in my patients. It's a very common issue across the board, so I'm happy to talk a little bit about it.
Okay, great. And Dr. Johnson?
Yeah, so like you said, I'm a pediatric neuropsychologist at Helen DeVos Children's Hospital. I'm heavily involved in their epilepsy program. I do see a wide range of different neurological conditions, but the majority of the children I see have epilepsy. Most of the families I see are through our outpatient service, but I do see some children for inpatient assessments as well prior to surgeries. My research interests are very broad. I have particular interests, though, in exploring neurocognitive outcomes that are associated with epilepsy and also looking at protective factors in general.
Great, great. All right, so let's start by addressing what I see as a critical issue related to this topic. We actually recently conducted a brain health survey that was completed by 184 people with epilepsy and family members. And the findings showed that 44% of people with epilepsy struggled quite a bit or a lot with memory, attention, or other problems with thinking. Yet, among those individuals, 77% did not receive any help from a neuropsychologist, occupational therapist, speech therapist, or other health professional to manage those problems. And furthermore, one-third of respondents said that the doctor who treats their epilepsy rarely or never asks them about their cognitive well-being. So the takeaway is that a lot of people with epilepsy struggle with cognitive function, yet many are not getting the support they need to manage these challenges on a day-to-day basis. Can each of you talk about why you think this might be the case?
Yeah, I guess as a neurologist, we're kind of the front line here, and it's very easy, I suppose, as a neurologist who's dealing with a patient with epilepsy to focus on, the I guess seminal symptom of epilepsy, which is seizures, and we worry very much about seizure control and side effects of medications and so forth. And as we know, epilepsy entails a whole lot more than that. And I suspect that you're kind of on the right track there. There's maybe not enough emphasis in training on the broad range of symptoms that patients with epilepsy deal with. Hopefully that's something that is improving as we kind of learn more and more about the broad effects of epilepsy. But I think that is probably the biggest barrier right now, at least on our end, and asking patients and addressing the issues properly.
Okay. And Dr. Johnson?
Yeah, I suspect that part of the underutilization of neuropsychology is that people can experience a cognitive issue even if they have normal functioning. So in those cases, people might compensate for their challenges, and it might not seem like they're having significant deficits in their daily lives. With children, I think some providers might think that a child is getting sufficient support if they already have an individualized education program or IEP, which often starts with some type of standardized testing. But those assessments can be helpful through the school, but they're often limited to just IQ and academic tests. So they often miss a lot of the deficits that are common in epilepsy, like memory and attention problems.
Right, right. And to what extent, at least in the adult population, do you think that lack of insurance coverage for cognitive health services plays a role in this?
Yeah, I think that's certainly an issue, and I often will struggle to get my patients who have clear problems the issues that they need. Part of it is just lack of insurance coverage, and part of it is just access. People who don't live necessarily in an area where people who can help them are readily available to them is another big barrier. But the fight with insurance companies, just getting patients to where they need to be for various different reasons is very much a huge barrier for a lot of people.
Right. Okay. So self-advocacy by patients and families is likely needed to help overcome some of these systemic barriers. What can people with epilepsy and caregivers do to identify cognitive difficulties, convey those difficulties to their healthcare team, and then effectively access services and resources that can help?
Yeah. Pardon me. I guess it is kind of incumbent on patients and families to be a little bit vigilant and pick up on, I guess, some of the difficulties that may not be obvious to somebody from outside. So everybody has their own baseline, right? We all kind of know what we expect ourselves to be able to do. And it's a lot easier for us and people who know us well to notice that there's something that's not right for us. And so when somebody does notice that there's some kind of a change or more difficulty than they are used to seeing, or they're seeing their loved one having a little bit more difficulty with things than is normal for that person, it's always important and appropriate to bring it up with your neurologist, your family doctor, whoever is helping you deal with these things, and bring it to light. And if you don't feel like you're getting the appropriate attention for it, don't let it fall by the wayside, because it's something that affects people every day in various different facets of their life. So it's important just to note those things and try to describe them as well as you can, and fight for yourself and make sure that you're at least getting the attention of the person you're discussing it with, I guess.
Right. Dr. Johnson, anything to add?
Yeah, just to bounce off from that, I would say giving very specific examples can be helpful, so that way it'll give your healthcare team a good understanding of the extent of your concerns and why you need additional services. I think it's also important just to educate yourself as well and ask lots of questions, develop good relationships with your medical team or other people that are involved in your care or your child's care, so that way they can be more aware if there are changes in your cognitive functioning.
Great, thanks. So Dr. Tank, can you review the broad range of epilepsy-related and treatment-related factors that can negatively impact cognitive function in people with epilepsy?
Yeah, there are many different ways in which somebody's cognition can be impacted. So first of all, of course, the seizures themselves, at least temporarily, will incapacitate people or cause them, direct issues with their cognition during the time of the seizure and shortly thereafter, what we call post-ictal symptoms. People will frequently have even maybe more subtle seizures that they're not clinically aware of that can cause some disruption in their thinking and their attention. In between seizures, people will have abnormal activity in their brain, which we can see in an EEG, and sometimes that's of the type that is maybe related to their epilepsy, and sometimes it's different types of abnormalities that may or may not involve the same part of the brain as those seizures. And those electrical changes in between seizures can very much have an impact on somebody's attention and their memory and their focus and their ability to function in a way that they expect to. Of course, many people with epilepsy have epilepsy because of some underlying brain condition, whether it's a traumatic brain injury or a previous stroke or something along those lines. And those underlying neurologic conditions can have their own cognitive impact as well. And the way in which we choose to treat people can also adversely affect somebody's memory and their thinking. Many, if not all, seizure medications at least have some potential to cause people excessive sleepiness or difficulty with attention or difficulty finding words or a lot of different things. So as Dr. Johnson was saying, paying close attention to kind of what your symptoms are and describing them as well as you can sometimes help us narrow down what may be the cause of your specific difficulty, but sometimes it is very difficult because a lot of these things overlap and it's not always as easy as picking out, one simple causative reason for somebody's troubles.
Right. Dr. Johnson, did you want to add anything?
No, I don't.
Okay, great. And so what are some examples of medical interventions that can address some of these factors and actually improve cognitive function?
Yeah, of course, it depends on what the underlying reason is. So if it's a medication side effect, sometimes it's just a matter of changing the medication or maybe splitting up the dosages so that you take less during the daytime and more during the night, so the side effects are maybe a little bit more heavily weighted toward when you would be asleep anyway. Sometimes it's doing more with medications to address the seizure control. That seems to be the bigger underlying issue with the cognitive problems the patient's having. Sometimes we find that we've exhausted medical options and we have to talk about epilepsy surgery, and there are certainly some types of epilepsy surgery in some ways to address medically refractory patients, which can slow the progression of memory loss or sometimes improve memory function. And sometimes it's a matter of just other issues entirely, where we know very frequently patients with epilepsy will suffer from depression, anxiety, and those conditions can cause or mimic memory problems and attention problems. So sometimes it's addressing that, and it's not a matter of the seizures really at all.
Right, great. And so, Dr. Johnson, can you discuss the role of neuropsychological evaluation in assessing cognitive difficulties in people with epilepsy? So just kind of talk about what it involves and what people should expect to come away with.
Sure. So a neuropsychological evaluation is conducted by a doctoral level specialist who has a license in psychology, and they also have extra training to understand how learning and behavior are related to brain development and functioning. So the neuropsychologist's goal is to identify how epilepsy and its treatment, like Dr. Tank had mentioned, might be impacting day-to-day functioning. The evaluation will help determine how epilepsy has affected a person's cognitive abilities and mood. It's designed to help understand an individual's strengths and weaknesses. It'll help determine the current level of functioning, and it can guide decisions about school and employment. Sometimes these assessments are used in the context of surgery, so it can help to identify functional areas in the brain as well. The neuropsychological evaluation itself involves 3 different parts. So the first part is the interview, which is very comprehensive. It's a lot of history gathering where the neuropsychologist is going to get information about a person's medical history, development, social-emotional function, educational background, a lot of different areas of their history. And the second part is testing, which takes up the majority of the evaluation. So we give standardized tests that measure a wide range of abilities. We're looking at intelligence, visual spatial skills, processing speed, learning and memory, language, higher order thinking skills or executive functions, attention, motor skills, and mood. And those domains are measured by asking a lot of questions. We use a lot of pictures, and sometimes we give people things to manipulate with their hands. So we might give them blocks or puzzle pieces, and we use those items to measure their brain functioning. At the end of all of the testing, we take a person's scores and we compare it to other people the same age as that person to determine whether or not they're performing within normal ranges or if there's significant differences that warrant attention. And then the final part of the evaluation is the feedback, where we give verbal review of the results and give some recommendations. So this is the bread and butter of what we do. So we're pulling all of the information together that we've gathered from the interview, from the test data. We interpret all of these different data points using our knowledge of the person's medical condition and history. And then the end goal is to provide a picture of how the person thinks and navigates the world. From there, we can give suggestions about the type of treatment that might be helpful. And then, like I said before, in surgery evaluations, we can assist the surgery team with trying to localize the focus of the seizures. Sometimes we use the evaluations as well to track decline following treatment, whether it's anti-seizure medications or brain resections.
Okay. So having done many evaluations, what do you see as the most common cognitive functions that are impacted by epilepsy?
So the number one problem that people mention is memory problems, especially when their seizures are poorly controlled. So it's about like 20 to 50% of people with epilepsy that will have some type of memory complaint. Some of the other top cognitive issues that I hear about are low processing speed. So this could be due to a combination of medication effects or more generalized effects of seizure activity. Attention problems are also very common. And then I often see deficits in executive functions, which are skills that help people carry out a goal.
Okay. And can you briefly discuss how neuropsychological evaluations are most often paid for in the pediatric population?
Yeah, so most insurance companies would cover a neuropsychological evaluation if there's a cognitive concern within the context of a medical condition. So there are a few insurances where it's more difficult to get coverage, but most will cover an evaluation if there's a referral from a neurologist or a primary care physician. But families can also request an evaluation through their school district in some cases, and this can be done by requesting something called an Independent Educational Evaluation, or IEE. So the child would first need to have some testing with the school, and if the parents don't agree with the results, they can request an IEE, which would allow them to get an outside opinion. And then from there, the school would provide some options that would be covered by the school district.
Okay. And then how does neuropsychological evaluation differ from the psychoeducational testing that's done in the school setting by school psychologists, for example?
Yeah, so both evaluations involve standardized testing, but in neuropsychological evaluation goes beyond psychoeducational testing in that it looks to understand brain behavior relationships. So the goal of the neuropsychologist is to look at how a child's brain or a person's brain functions and how that functioning impacts their behavior and learning. There tends to be more domains that are looked at as well, so it usually takes a lot longer than a typical psychoeducational evaluation. But by having more of a comprehensive approach, the neuropsychologist is able to determine why a person is having certain difficulties, and then this can inform treatment. Right.
And is there, in terms of seeing a neuropsychologist who is affiliated with or works with a comprehensive epilepsy center, I would imagine that there would be additional benefits in doing that just simply because of that practitioner's familiarity with epilepsy as opposed to maybe a neuropsychologist who is less familiar with epilepsy.
Yes, definitely. So I think not only for the more comprehensive training that a neuropsychologist has in that setting, but also that person would be connected with a person's medical team. So there would be a lot of shared information to track their cognitive skills over time.
Great. Dr. Tank, in the adult population, are there ways to get insurance coverage for neuropsych evaluations outside of the context of pre-surgical evaluation or, say, post-injury rehabilitation?
There are, yes. It's a little bit more challenging in our world because there are fewer resources for adults than for children. We can't use school systems and so forth, and so the things that really, I guess, help us most often is if we can pose it as a question that needs to be answered. So if somebody is telling me that they have some worsened problem with their memory, is it because their seizures are under bad control? Is it because their depression has worsened? And I maybe can't sort that out on my own, and I need the help of a neuropsychologist to help me get to the bottom of that. If I can prove that the test is not just to quote unquote, form a baseline and kind of know how the patient's doing, but is actually diagnosing and helping me get to the bottom of a problem so that I can effectively diagnose it and treat it, that's usually very helpful. And as Dr. Johnson said, it's, pardon me again, it's very useful if you can frame the cognitive problem in a way that you're showing that it's a result of the underlying medical condition. So if somebody's having some sort of cognitive decline and you believe it's related to their seizures, most insurance companies will cover that. And sometimes we have to fight them about it, but we're usually successful.
Okay, great. And then this one's for both of you. After having had a neuropsychological evaluation, how common is it for based on the results for you to then refer the patient or family on to another provider, another professional who can specifically implement or help implement some of the strategies that are outlined in the end part of the neuropsych evaluation?
Yeah, so I'm doing that the majority of the time. Okay. So that might be through outpatient therapies. I might refer for occupational therapy, speech-language therapy that's within the hospital or a hospital that's closer to the patient's community. And then sometimes I'm giving recommendations to the school. So it might be that a child needs special education services, and then I'm very specific about the type of resources that they should have based on the results that I have.
Okay. Dr. Tan?
Yeah, I agree. I very much appreciate and respect the recommendations that I get from our neuropsychologists when I get a patient back from them, and I try my very best to implement those strategies and put in any consults or order any kind of therapies that is recommended by that team to help the patients do the best they can.
Great. All right, so we've talked about how to improve cognitive function through medical interventions, but now I'd like to discuss day-to-day behavioral and technological strategies to either improve cognitive function or compensate for cognitive deficits. Let's start by talking about memory. As you both mentioned, this is probably the most common cognitive complaint among people with epilepsy. What are the different types of memory, and which are most likely to be affected by epilepsy?
Yeah, Dr. Thompson, I'll let you answer first, so you'll be better.
Sure. So there's three different parts, or three different processes of memory. So the first is being able to encode the information. So you have to get the information in to begin with. There's retaining it. So you have to keep that information in mind. And then you have to be able to retrieve it or pull that information out. So then for all of those processes, there's three different types of memory. There's declarative memory, or it's sometimes called explicit memory, and this is related to remembering facts or personal experiences. There's something called prospective memory, so that's remembering to do something in the future, and this relies a lot on your executive functions. And then there's non-declarative memory or procedural or implicit memory. So these are memories that rely on skills or habits. So like riding a bicycle, you're using your procedural memory. You don't need to put too much thought into remembering how to do that skill. So the type of memory that is most impacted in people with epilepsy is declarative or that explicit memory, especially when it comes to learning new information or recent information. So they tend to have the most difficulty with pulling that information out or retrieving it. So I'll see that when I give multiple choice measures or measures where there's a verbal cue, they're able to recall it. So that tells me that they got the information in, but they had a hard time pulling it out.
Okay, great. And then other terms that are also used are kind of short-term memory and long-term memory. How do those relate to the concepts that you already discussed? And because I think maybe a lot of people think about memory in those terms. So can you kind of,
So when people talk about short-term memory, I think they're often referring to something called working memory. So that's more of a executive function type of task. So it's the ability to hold information in your head in order to do some type of task. So when I see kids that have issues with this area, I'll often hear parents say, I gave my kid 4 things to do in the morning, and they did 1 or 2, and they came back and they said, what did you say again? So that's a good example of a kid that has poor working memory, but a lot of times it's referred to as short-term memory. And then long-term memory is just the ability to recall information that's been learned over a longer period of time.
Okay. And then what are some of the day-to-day strategies and technologies that you've found to be most helpful for people with epilepsy who struggle with memory?
So the most effective training that or strategy that's been supported in research is something called strategy training. So for this approach, you're teaching people ways that they can compensate for their memory problems. So they can do this through internal memory aids, like using visual imagery, rehearsing what they need to learn using mnemonics, or they can use external memory aids, so like using notebooks, checklists, voice organizers, using their cell phones or other devices that would reduce memory lapses. So the external memory aids are the most effective, especially for people that have very severe memory impairments, and it's something that could be easily learned.
Okay, great. And I'm sure when we get to the discussion portion, we can ask other people to share what's worked for them as well. So often when people describe or what people describe as memory problems may actually be more related to attention. So for example, if you set your keys down and later can't find them, it may seem like you forgot where you put them when in fact you never noticed where you put them down in the first place. So can you talk about attention difficulties, including ADHD, and some of the most effective strategies for coping?
Yeah, well, I talked about this a little bit before, but learning is very dependent on having good attention. So if you think about it, you have to pay attention in the first place in order to store information. And unfortunately, attention problems are very common in people with epilepsy. In fact, attention deficit hyperactivity disorder, or ADHD, is more common in people with epilepsy than the general population. So it's about 32% versus 6%. But a diagnosis of ADHD is more than just your usual lapses in attention. So in order to have that diagnosis, you have to have 6 of 9 different symptoms, and they have to cause significant impairment in a person's daily life. In order to treat ADHD specifically, it's best treated with medication. So psychostimulants are considered the first line of treatment, but there's also non-stimulants that a person could use. They tend to be less effective, but they are available and are helpful for some people. And then in some cases, a person can use environmental support, so things like academic interventions, so allowing a student to have more breaks, having more hands-on teaching approaches. And these academic interventions are not just for elementary or high school. A lot of colleges will allow these types of interventions too. So I've seen where people will be able to take tests in a separate area so that they're able to focus better. And then for children, you can also use positive reinforcement, like behavioral systems that can improve their focus attention. But those environmental strategies really depends on the severity of the attention problems. So research has shown that for kids that have very severe ADHD, the most effective treatment tends to be medication.
Okay.
And just to add on to that, with the idea of ADHD in epilepsy, a lot of physicians have concerns about treating epileptic patients with stimulant medications because in high doses, stimulant medications can cause seizures, even in people without epilepsy. And for that reason, a lot of people will shy away from prescribing Adderall or Ritalin or those medications that, as Dr. Johnson said, are the most effective treatments for ADHD. When in fact, there's a fair amount of research to show that in normal therapeutic doses, those medications are very safe in epileptic patients and are not more likely to cause seizures. So that's something that a lot of physicians are not aware of, and maybe if you as a patient are noticing that you're kind of running into that barrier, I would bring that up with your physician and just make sure that they are aware that, you know, as long as you're not abusing them and you're using them at appropriate doses, they help you in terms of memory, and they shouldn't hurt you in terms of seizure control.
Yeah, and along those lines, Dr. Tank, I think a lot of times ADHD is thought of as a pediatric condition that really only is typically diagnosed in childhood and treated in childhood, and some people kind of outgrow it. But I imagine there are a fairly high percentage of adults who live with ADHD and epilepsy who maybe have never been evaluated for it, maybe have never thought that, you know, this is a problem for them, and have never therefore thought to ask about how it could be treated. Do you find that that's the case, that it's maybe underdiagnosed in adults? And if so, what can adult patients do to kind of explore that possibility if they feel like they're struggling with attention?
Yeah, I do feel it is probably under-recognized, and it's a condition that we've become much more aware of in recent years. So we now very much are keyed in to notice that in children and younger people who are in school and having difficulties with behavioral problems or academically, and we wonder, you know, is that maybe part of the thing where, you know, several years ago it was not such a readily known condition. So patients who are a little bit older when they come to us and maybe even developed epilepsy later in life might have kind of passed through that phase where most people get diagnosed because when they were younger, it wasn't such a prevalent notion. So I do see patients who I think have had long-standing issues with attention problems, and maybe that's not entirely related to their epilepsy. And it is, I guess, important if you feel that's something that you've struggled with for a long time, just to mention to your physician that that's the case, and we can try to direct you to the right appropriate testing and maybe the appropriate medical treatment to see how you respond to it, and if you do kind of meet the criteria for that condition, and if you should be treated beyond just trying to control your seizures or whatever else we may otherwise think of as contributing to your attentional difficulties.
Okay, great. So closely related to attention is executive function, and Dr. Johnson, you've mentioned that. Can you give a brief overview of the types of cognitive processes that fall under this category of executive function?
Sure. So executive functions are higher order thinking skills that help a person function from day to day. So you can think of these skills as an air traffic control system. So an air traffic controller has to safely manage many different runways, filter distractions, prioritize tasks, set goals, and control their impulses in order to make sure that the airport runs smoothly. So all of those types of skills are similar to what the brain has to juggle. So there's 8 different types of executive functions that I'll talk about. Some people believe there's much more, but I'll focus on the 8. The first one is impulse control. So this is being able to think before you act. So people with poor impulse control might blurt out inappropriate things. They might have very risky behaviors. So you might have an example would be like an adolescent who bolts across the street without considering the traffic. The second executive function is emotional control, so being able to keep your feelings in check, not having a complete meltdown when you're told you have to turn off a video game and do your homework. The third one is flexible thinking, being able to adjust to the unexpected, thinking outside of the box. The fourth that we've talked about a little bit before is working memory, being able to keep information in your mind in order to complete some type of task. The fifth one is self-monitoring, checking to see what you're doing, so being able to stop and look and make sure that you're doing a task correctly. Next is planning and prioritizing, so being able to decide on a goal and then make a plan for it. So people might have a really hard time managing big projects if they have difficulties with planning. Next is task initiation, so being able to get started. People with issues in this area are often viewed as chronic procrastinators, always doing things last minute. And then the last one is organization, so being able to keep track of things both mentally and physically. A person with poor organization might misplace things often, forget to turn in homework, or forget deadlines, or lose their train of thought. So you might notice that some of those executive functions overlap a little bit with memory problems. So I often see in my practice people that will come in with complaints of memory lapses, but they actually have deficits in executive functions rather than a true memory problem.
Right, right. So because our time is limited, let's focus on one concrete example that involves multiple executive functions. Let's think about the task of applying for a job. So that involves initiation and time management, planning, persistence, self-monitoring, working memory, and a number of other skills. Can you talk about how people can kind of overcome some of those deficiencies in these skills to accomplish the task of applying for a job?
So there's a lot of simple strategies that a person can use for applying for a job. So they can use timers to keep track of the time that they need to dedicate to search for a job. So maybe they could set aside 30 minutes a day to look for a job of interest. There's a lot of worksheets that are available online that a person could download for free, and those worksheets can help a person keep track of each job application and the steps that they need to complete to follow up. They can also use calendars or alarms on their phones to keep track of deadlines or appointments that they have for interviews. But if a person is still having difficulty navigating that process, they could also reach out to a vocational trainer who could help with that application process. So Michigan Rehabilitation Services is one organization that offers vocational training, but if a person is still in school, a lot of times the school district offers a vocational trainer as well.
Great, great. Those are some great examples. So can you, Dr. Johnson, can you briefly review some of the other cognitive difficulties that can go along with epilepsy that we haven't yet discussed?
So one that I often see is just general intellectual deficits, and this really depends on the severity of epilepsy and the type of disorder. So there's certain types of epilepsy syndromes that are more prone to intellectual disabilities than others. So like Dravet syndrome or Lennox-Gastaut syndrome, they're commonly associated with intellectual disabilities. Some other challenges that I see are motor slowing or language deficits. So one language issue I often see is a person will say that they have a hard time getting their words out. So it's like the word is on the tip of their tongue, but they can't get it out. So there's a lot of word finding issues that I see as well.
Okay. And then we mentioned earlier processing speed. Is that also fairly common with the combined effect of both the epilepsy and the medication? Is that something that is also fairly common?
Yeah, I would say that it's I see it just as often as memory and attention deficits.
Okay. And then for any of those things that we mentioned, like the slowed processing speed or word finding difficulty, for example, are there any general strategies for dealing with that? Like I'm thinking of, of your in a conversation with someone, for example, and you're struggling with trying to find words, or maybe struggling with trying to keep up with the details of the conversation. Are there strategies that people can use to kind of address that proactively, or compensate for those difficulties?
Yeah, for the word finding difficulties, it's often helpful to think around the word. So if you can't think about the specific word, try to describe other things about that word, and then sometimes that helps with pulling it out. For the processing speed difficulties, I often suggest accommodations through school, so a person can get extra time to complete things, or they can get a reduced workload. And again, this could be not only in elementary and high school, but also colleges can offer these type of accommodations as well. Great.
Dr. Tank, can you talk about some common types of epilepsy and how localization and etiology influences the types of cognitive problems experienced?
Yeah, absolutely. So as I'm going to bet many people on the line know, we divide epilepsies into two broad categories. So an epilepsy is either generalized, meaning the seizures start broadly over both sides of the brain all at once, or we call it a focal epilepsy, meaning the seizures start in one area on one side of the brain. People with generalized epilepsies may have that type of epilepsy because it's an inherited condition. Things like juvenile myoclonic epilepsy fall in that category. Or it may be the consequence of some broader condition and may manifest with something like Lennox-Gastaut syndrome, which necessarily involves some cognitive impairment or intellectual disability. Otherwise, focal epilepsies, not only will a patient's seizure symptoms very much change with where in their brain seizures are coming from, but the cognitive difficulties may as well. So the most common locations for focal epilepsies are the temporal lobes. In almost all people, the left temporal lobe is the dominant temporal lobe for speech and language. So people who have epilepsy arising from or involving the left temporal lobe very commonly will have some of these language difficulties that Dr. Johnson was describing. Whereas in most people, the right temporal lobe helps very much in visual, spatial sorts of things. So people who have epilepsies involving the right temporal lobe may have a little bit of difficulty in navigating and kind of visually planning things and things of that nature. Next to the temporal lobe, the most common site of origin for seizures is the frontal lobe. So people with frontal lobe epilepsy oftentimes will demonstrate some difficulties with executive function, as Dr. Johnson was explaining. So problems with planning and problems with emotional regulation and things of that sort. So where in your brain your seizures come from, if you have a focal epilepsy, very much kind of determines what sort of cognitive problems you may suffer from.
Okay. And cognitive challenges don't always map perfectly to the person's seizure focus. So can you talk about how neuronal networks beyond the seizure focus can still impact cognitive function?
Yeah, we're learning more and more over time that seizures aren't as cut and dry as you have some sort of structural problem in your temporal lobe. That's where your seizures come from. That's where your seizures are. In fact, it's much more complex than that. And your brain has kind of diffuse connections. And those connections are something that we call a neuronal network. And people with epilepsy will often have seizures that involve different, what we call nodes in the network. So different parts of the brain will become involved in those seizures. So you may, for instance, have seizures that begin in an area of your parietal lobe that then very quickly travel to your temporal lobe. And then you develop some language arrest or typical speech problems, even though that's not necessarily where your seizures arise. So we're, I guess, as time goes on, learning more and more about what kind of the more common types of connections between areas of the brain are. And that does very much impact the type of difficulties that somebody will have, not just during their seizures, but in between seizures and some of the more day-to-day issues like we're talking about now.
Right. Okay, great. So for those with drug-resistant epilepsy who are exploring surgery or neurostimulation therapies or dietary therapies, the primary focus of decision-making tends to be seizure control. So what are some potential cognitive impacts, either positive or negative, of these different therapies that should also be considered?
Yeah, there are both positive and negative depending on what you're discussing and where somebody's seizures come from. We try very much using the help of people like Dr. Johnson and using some kind of advanced imaging techniques and other sorts of things to figure out where somebody's language centers are and how well their memory on the affective side functions before we discuss any potential resection or removing any parts of the brain if you're a candidate for that sort of surgery. People who do end up getting a recommendation to have a part of their brain removed to better control their seizures, we try to advise them how much of an impact it may have on their memory because it is, as I said, most seizures, for instance, do come from the temporal lobe, and your temporal lobe is extremely important in memory function. And if you have seizures that come from one of your temporal lobes, and that temporal lobe does still on testing look like it very much carries some functions in memory and is doing some benefit to you, then you probably will suffer some consequences if you have that part of your brain removed. Now, whether it's completely removed by surgical resection or maybe there are other less invasive ways to try to prevent that tissue from causing seizures. So we have things called laser interstitial thermal ablation, where we kind of use a fiber optic cable to heat up and damage that part of the brain so it doesn't produce seizures any further. That can be a little bit less cognitively damaging or have fewer cognitive side effects than a resection. So that's something that we try to discuss in patients who are being considered for that sort of therapy. Neuromodulation is also a very interesting topic as it relates to cognitive side effects. So many people who either don't want to have a resection or can't have a resection because of the maybe underlying importance of the part of the brain where their seizures are coming from, we will offer what we call a responsive neurostimulation system, where you will have some EEG electrodes implanted onto the surface of your brain or within the tissue of your brain, and we use that to try to recognize and interrupt your seizures with a stimulation device. There's some pretty interesting data that shows that people who have that type of system implanted will actually have improvements on neuropsychological testing after their epilepsy surgery. So it seems to provide not just benefits for controlling seizures, but some benefits in helping with attention and memory as well. So that's a very appealing notion to a lot of people. Other types of neurostimulation, for instance, a vagus nerve stimulator, probably doesn't really do much one way or the other in terms of cognition. However, if you, for instance, are somebody who has depression and that maybe slows your cognitive processing speed and affects your attention, it does help with depression, so it could, in a roundabout way, help with your cognition as well. And then there's a new device, at least newly approved for epilepsy device, called deep brain stimulator. which works differently than the responsive neurostimulator device, and we've been using it here in the United States for a long time to treat movement disorders like Parkinson's disease. That seems to, at least in that condition, actually have some negative consequences for cognition. So there are a lot of different concerns and a lot of different variables to look at.
Right. Right. And as far as ketogenic diet, either Dr. Tank or Dr. Johnson, either of you aware of any potential cognitive benefits or negative impacts of this ketogenic diet?
Yeah, Dr. Johnson, you see, I'm sure, a lot more of it than I do, so I'll yield to you.
I actually haven't seen a lot of children on a ketogenic diet. I think there can be some cognitive improvement, though, if their seizures are under better control, though.
Mm-hmm.
Yeah, I agree. It's not something that we use a lot in the adult world,
right.
But yeah, absolutely, that's been my experience as well.
Yeah, and sometimes the cognitive benefit is sort of indirect, an indirect result of the improved seizure control. So, okay. So what are some of the different types of professionals? We've mentioned some of them that people can enlist to help with cognitive challenges.
So occupational therapists and speech-language pathologists and speech therapists can help with a lot of cognitive rehab and helping with language difficulties that people have when they suffer from epilepsy. Those are the most common places I turn to. And certainly we talked about kind of the underlying mental health aspect of things. So just seeing a psychiatrist, psychologist, a therapist of some sort, or getting medical treatment for underlying mood issues that may be contributing to cognitive problems. Those are the most common things that I'm experienced with. Dr. Johnson, I don't know, beyond that, where you turn.
Yeah, in addition to that, vocational trainers, like I had mentioned before, there's also community living support. So they are individuals that will help a person with their day-to-day living skills if they have an intellectual disability. So their goal is to help a person be as independent as possible. And they're available for children and adults. But they work on things like taking public transportation, being able to take care of personal hygiene, being able to do laundry, those type of independent living skills. And then I also turn to a lot of resources within the school. So if a person is having a hard time with their academics, I might recommend a paraprofessional who can give one-on-one support in the classroom. It might also be a special education aid within a smaller classroom setting size. And then physical therapy could be helpful for some kids as well.
Okay. And you mentioned community living supports. Are those typically provided through the community mental health system most often?
Yes, they are.
Okay. So yeah, that's something to consider if you have a intellectual or developmental disability, that you could potentially receive additional services through the community mental health system. So, okay, great. So we've talked about some specific cognitive problems and specific strategies for dealing with those problems, but can you talk about some more general behaviors that can kind of help with overall cognitive function?
I think that anybody has the potential to kind of maximize what their brain can do with some very simple lifestyle choices. So making sure that you're getting adequate sleep, that you're eating well, that you're managing your stress as well at home as possible. I very often will have patients come in and complain to me about their memory, and I'll ask them about their sleep, and they'll say, yeah, I have sleep apnea. I don't wear my CPAP at night because it makes me uncomfortable. I probably am not that well rested. And you know, it's obviously there's underlying neurological condition there that is something that needs to be managed. But to make sure that you're taking care of yourself in some of those more elementary, and if you take a step back, I guess maybe a little bit more intuitive ways, can really allow your brain to maximize its own potential.
Great. Yeah,
And
Dr.
just
Johnson.
to highlight the importance of getting sufficient sleep, I often see where people will have very significant attention problems because they have such poor sleep quality, but once that's taken care of, their attention problems completely resolve. So it's very important for, like Dr. Tank said, memory, attention, a lot of different cognitive skills.
Right, right. Excellent. All right, so before we start the Q&A portion of the call, do either of you have any closing thoughts that you'd like to share on this topic?
I guess the one thing that I would like to say is, it's important to be your own advocate for this sort of thing. It's if you make it easy for your treating physician to overlook the issue, they may overlook the issue. And if you're having more troubles than you are willing to tolerate, just make sure you ask and bring it up and try to get the appropriate evaluation and find your way to the right resources, because there are a lot of ways to help, and this is a very common issue in epilepsy patients, and something that, as a whole, probably the medical community is not doing a great job of addressing.
Thanks. Dr. Johnson?
Yeah, I would just echo that as well. I think a part of, like I said before, being a great advocate is to educate yourself. I feel like there's a lot of well-intentioned families that I work with, but they just don't have the information. So there's a lot of different ways that you could educate yourself. Part of it is leaning on the Epilepsy Foundation, which has a wealth of resources. There's also advocacy agencies. I think the individual is their best advocate, though. They know their symptoms the best, or the parent knows their child's symptoms the best. But sometimes just even learning the different laws of the states and the resources that are available will be helpful to get the types of interventions that are needed.
Great, great. Okay, who would like to get us started with a question?
Hi, this is Lorraine McArthur. I had a question. I have a 10, almost 11-year-old son that has generalized epilepsy and also has an intellectual disability classified as a moderate to severe level. And you touched on several things that are impacting him currently in school, especially when you talked about the executive functions. He's having trouble with impulse control, emotional control, and flexible thinking. So I'm just wondering if you have any suggestions to help him improve in these areas, because he's not, he just moved to a new school, and he's having trouble adjusting and meltdowns when he's told to do tasks, and just even at home we're having issues. So any suggestions to help him improve in this area?
I think the biggest thing that would be helpful is for him to have external environmental support. So I'm not sure if the school already has like a behavior plan in place. But something like that would be helpful, where there's a lot of positive reinforcement, where a behavioral interventionist comes in and does an analysis to see what triggers are going on that kind of provoke the behaviors to reduce the meltdowns. So the biggest thing would be to start there, first having an assessment to get a better sense of behaviors and what would be effective for him. And then the second would be to develop a behavior plan that's specific to his needs.
Okay, thank you. We kind of do have a behavior plan. He went away from it because he moved schools because he moved on to the 5th grade, which is now in a different building. They have it there, but he was able to move past it at his last school, and maybe I'll talk to them about seeing if they can try to implement it there where he is.
Yeah, and I would recommend that they do a functional behavior analysis, or FBA. So they may have already done something like that when he first started getting a behavior plan, but it's important for them to revisit that, especially as he gets older, because some of the strategies that they first started may not be as effective now. So I would ask them to start there, and then if they need to develop a new behavior plan, then that might be the direction that they need to go.
Okay, thank you.
I did actually learn about at our back to school conference in looking for a speaker for that. I actually did learn that there's another type of professional called an educational therapist, and they kind of can serve as almost a coach where they provide one-on-one support specifically with executive function challenges. So if you wanted to talk with me afterwards, I could let you know the person who spoke at that conference, and she may have some good ideas as well.
Okay, yes, I would appreciate that.
Okay. Other questions?
Hi, my name is, I'm sorry.
Go ahead.
Go and then I'll speak. Okay, my name is Michelle Connor. I'm an EEG technologist. I record people's brainwave activity, but it's interesting. I have two sons, and one has central auditory processing disorder, and the other one has a lot of mental issues. I adopted my nephew through the state of Michigan, and I'm listening to this, and there's some similarities in regards to the executive functioning and all. I get a lot of support. Both my children have had IEPs, and in regards to the last lady that spoke, I'm wondering, I use the county, even though the county services, let me close my door here. I have Blue Cross insurance, but I also have Medicaid because I adopted a child through the state of Michigan. I use the county for a lot of services, and I don't know if a lot of people understand that they can still use the county even though they have private insurance. And I use wraparounds, and I use Easter Seal services, and that's something that maybe the last lady who spoke that she might want to check into, because wraparound is very intensive, and they do home-based therapy. The Easter Seals does home-based therapy, and wraparound is involved. They go to the school, they come home, they do a lot of training. So that's something that the other lady might want to look into in regards to her fifth grade child.
And can you talk a little more specifically about what you mean by the county, like what specific department or division, I guess, are you talking about?
Right. Well, each county, it's more like, I guess what I should do is probably clarify that a little bit. It's more mental health.
Oh, so like community mental health?
Yes.
Okay.
I should have said that.
Got it.
Community mental health. And I didn't use that for my older child who has central auditory processing disorder, but for my younger child, and that ADHD falls into that category. I don't know what kind of services they have for patients who have epilepsy, because I don't have a child, but I'm wondering if the county has something that they could offer. Do you know anything about, do you know, Russ, if the county helps patients who have epilepsy in any kind of way?
Yeah, typically if the epilepsy is part of a developmental disability, people can receive services through it, yes. And also
right.
people with significant mental illness can also qualify for services through community mental health as well. So anyone who has epilepsy is also struggling with depression or anxiety or any other psychiatric disorders can also access those services.
Right, and it's pretty intensive. It's better than private. I mean, I know that there's certain things like for neuropsychological testing, I prefer going to an outside agency because both my children have had neuropsychological testing throughout the years, and I prefer going. I take them to University of Michigan Hospital to their department, and I'm happier than having it through the school. But then in regards to other services, I'm happier with the county.
Okay, great. Yeah, yeah, certainly community mental health has the added benefit of doing person-centered planning, which is a process whereby they work with the client to identify what their goals are and then what steps and what services and supports are needed to reach those goals. So that's just an added kind of case management function that they can provide as well. So thank you for that.
You're welcome.
Yeah, there was a gentleman who has also started to ask a question earlier.
Yes, this is Greg.
Yeah.
What does mild cognitive impairment mean?
That's a good question. Yeah, that's a term that can often be used, mild cognitive impairment. Sometimes it's used in place of like dementia, or it can be used in other contexts. Dr. Johnson, can you talk about what that term means? Or?
Yeah, so we often use that diagnosis for people with epilepsy if they have cognitive challenges. So a person could have a mild neurocognitive disorder without having major deficits in their functioning where they can't be independent. So a person might have very specific challenges in areas of attention or executive functioning, but it's related to their epilepsy diagnosis, so they could get that diagnosis.
So basically much of the stuff that we've been talking about today would fall under that umbrella term?
Yes.
Okay. And is that that's an actual diagnostic category as well? Is that true, Dr. Tank? Is that something you found in adults as well, that can be an actual diagnosis, mild cognitive impairment?
It's an actual diagnosis, and we'll often use that, as Dr. Johnson was saying, when somebody has some clear issues that don't fit neatly into the category of dementia or whatever else. It's almost maybe not the best way to put it, but it's kind of a catch-all term for somebody who has some sort of cognitive problems, but not maybe a more specific diagnosis than that.
Okay. And does that diagnosis sometimes open the door for insurance coverage for other or related services?
Yes. So if I'm referring somebody for neuropsychological testing, not in the context of a pre-surgical evaluation, I will usually use that particular diagnosis.
Okay, great. That's good to know. All right, other questions?
I have a question.
Go ahead.
Okay.
You guys talked about an occupational therapist. I was curious to see, is this an individual thing, or is this like a public resource that you could go to? Let's see.
So occupational therapists are typically privately employed, not generally, at least in my experience, available as a public resource. Although if you're, seen through some other sort of, public program, yes. But if your physician specifically referring you to an occupational therapist, it's a medical professional, and it's typically going to be billed through insurance and that sort of thing, if that's what you're asking.
Oh, okay. Well, that would lead me to a part two of that opening statement. Okay. Are there resources for people with epilepsy and seizure disorders for career opportunities and pathways for safe jobs? I'm in the middle of an ADA case with my job right now, and they're basically trying to prevent me to get back to work because it's a hazardous working environment, and I'd like to try and maybe I'm at a crossroads and I need to think of a new career, and I'm wondering what options I should get into, or is this just a personal situation I need to be my own advocate of?
Well, I think, as was mentioned a couple of times, the Michigan Rehabilitation Services, where you can work with a vocational rehab counselor, it would be a great starting point.
Okay.
And they can, talk not only about the epilepsy and seizures and their potential impact on job functions and safety concerns, but they can also work with you on any cognitive issues that may impact your ability to perform job functions. So, and help you provide additional training and supports and job coaching and job placement.
Job coaching and placement would be the
yeah, exactly, and also help you identify possible accommodations in the workplace that could help you. So that would be definitely a great place to start, is contacting Michigan Rehabilitation Services. And again, I'd be happy to talk with you more about that if you want to give me a call at some point.
Awesome, thank you.
Okay, other questions?
I have one. My name is Jill. My daughter was diagnosed with benign Rolandic epilepsy last year. She's 9. And this webinar caught my attention because she has suffered from attention issues that we've never really fully looked into. I just kind of figured it was normal for, her age. And I was just wondering from Dr. Johnson, do you see a lot of patients that have the BRE type of epilepsy, or is that, I guess I'm trying to understand with my daughter if some of her behavior things are normal or if it's linked to, I'd never even realized it could be linked to epilepsy.
Yeah, and it could. I do see children with BRE that do have not only attention problems, but issues with executive functioning. So the tests that we give, they would compare to other kids her age to see if it's normal for her age range or if it's something that's different that needs treatment. Because you would expect kids to have some level of attention problems.
Right. Would you suggest going to my school first about it, or would I seek help from you first?
I would recommend seeking a neuropsychologist, just because with the schools, they typically just do IQ and academic tests, so they're going to miss all those other areas. And I've seen where a lot of school districts will ask families to get a medical diagnosis of ADHD anyways.
Okay, thank you.
So what you can do is you can get a referral from either your neurologist or your primary care physician should be able to do it as well.
Thank you.
Welcome.
And I think you raised an important point there, is that sometimes types of epilepsy that actually have the word benign right in them, like, or are typically thought of as more benign epilepsy. Sometimes kids often will outgrow them, like childhood absence epilepsy or benign Rolandic epilepsy. Sometimes there can be persistent cognitive challenges that even after the child has outgrown those seizures may still persist. Is that correct, Dr. Johnson?
Yeah, that's correct, yeah.
Yeah, okay. Other questions?
Hi, my name's Rebecca. I'm sorry. Go ahead, Rebecca.
Okay. I'm calling regarding my daughter. She's 23 years old, and she's having quite a few seizures. She has larger seizures in her sleep maybe once every 3 or 4 months, but lately she's been having focal seizures almost every day. She's attending school, but we were wondering, her doctor actually is in the same practice that you're in, Dr. Tank, and we've communicated over my health, and she has huge memory issues where she's forgotten events like certain Christmases, camping, things like that, and so she's been referred for a neuropsychological evaluation. And I guess my question comes down to insurance. I guess I was assuming it would be covered. In the message we got, it said something about her going for a baseline, and you said that wouldn't be covered by insurance. That's what I'm wondering. What do we need to do?
Yeah, well, so I didn't mean to make that as a blanket statement. I just, what I was trying to indicate is that sometimes you'll meet more resistance from an insurance company if you're not necessarily looking to address a new issue or trying to answer a specific question where you're figuring out between two potential causes of somebody's problems. I do know with our system in particular, before anything gets scheduled, our schedulers and prior authorization office staff people will contact your insurance company and make sure that it's going to be covered before they put you on. So you're not going to be pinned with a bill after the fact, and nobody's going to kind of pull the rug out from under you. So if you're doing it through spectrum, somebody's going to look into that and make sure that it's all going to be appropriately handled before you set foot in the door for testing.
Okay, that's that's reassuring. I have one more question. Once, obviously, her seizures are not controlled right now. We don't even know what kind they are. But usually, if the seizures become controlled, do the memories come back? Do the like hers are from like a year and a half ago that she's forgotten, but she also has recent things like she missed a meeting because even though she was in the room when it was announced, she doesn't even remember hearing about it. Do those things improve once the seizures are controlled usually, or is that a permanent?
It's kind of an unusual memory issue to begin with, to lose kind of long-term memories like that. So I can't tell you I have a lot of personal experience with that particular sort of memory loss. I can tell you just anecdotally, for whatever it's worth, I do have one patient who, when he first came to see me, was having a lot of issues with long-term memory and with some changes in medications. He is actually much better able to remember things that happened in his past. I don't have a good explanation for that because I think that's a little bit atypical. And I don't know, Dr. Johnson, if you can shed any more light on that, but that's outside of my comfort zone, I guess.
I can answer that for you.
Uh-huh.
I have seizures like on an infrequent basis, but when you do have a seizure, your brain is pretty much knocked out for a week or so. But like as soon as you get further away from the incident, your brain will kind of regroup itself and the memories will come back slowly. So in the immediate future from an event, like you'll forget bits and pieces of everything for if and any what reason, long or short term. That's just how it is.
Sure, yeah, in the immediate aftermath, yeah, sure, absolutely, I'm familiar with that, yeah.
Because that's almost scaring her as much or more than the seizures.
It's the way it's awful, but yeah.
Right, and more kind of...
Just to chime in, from neuropsychological testing, I will see where memory gets better on our test measures when the seizures are well controlled. It's like there's less seizures that are occurring, so it's less impact on the brain. And then when people are getting off some of those anti-seizure medications, it can be helpful as well.
Oh, yeah, it's like I don't foresee that happening, but she's also lack of sleep, I think, because of the medication. She's not sleeping good at all right now, so that's adding, I think, to the memory and the seizures.
Right.
Sure.
Probably.
Okay, someone else started talking. Was it maybe Kathy?
Yeah, I just wanted you to kind of give me a better explanation of what the type of or what you guys do and what seizures you deal with, or you deal with all types of seizures.
All types of seizures. There's no particular variety of seizure that we don't see in our practice, I don't think. There are no restrictions or any kind of limitations on our experience or, I guess, expertise in dealing with different forms of epilepsy and different types of seizures.
Right, and cognitive function is something that can be impacted by virtually any type of epilepsy, right? So it doesn't, you know, that you may have corresponding things that are more likely with focal epilepsies versus generalized epilepsies, but in general, really any type of epilepsy has the potential to impact cognitive function.
Yeah.
Okay, other questions? Got about 5 minutes left.
Hi, it's Lorraine again. Oh, I'm sorry.
Go ahead.
I'm sorry. Doctors, I was just saying, has anybody ever came up to you and said that they went for a walk and their memory was they could be walking and the next thing you know, like for me, I was walking and the next thing I know, I was on my front porch. I don't know what happened in between there. But in crossing streets and stuff, I don't know. I don't remember seeing any cars or anything like that. So has anybody ever told you about that type of seizure?
Yeah, sure. Yeah, so I hear complaints like that all the time where patients will describe just sort of, losing a little bit of time and going from one place to another, or they were engaged in one activity and then when they regained awareness, they were doing something completely different. That's actually a fairly common thing. Yeah, that's when patients describe that to me, I'm always more concerned that that's evidence of a seizure that happened than of any cognitive or direct memory issue. But yeah, that very much is a common way for a seizure to manifest.
Right.
And what type of seizure is it that you call that?
We just kind of, in almost all cases, we'll broadly call that what is now known as a focal unaware seizure. The older terminology is a complex partial seizure.
Okay, great. Another person started asking a question. Go ahead.
Hi, it's Lorraine again. I talked about my son before. I wanted to revisit one more thing regarding the executive functions you discussed. He's on a ketogenic diet along with seizure medicine, and we're weaning him off the seizure medicine, so he's pretty well controlled with his seizure activity. He does have that abnormal brain activity as it shows on his EEG, so we have about 2 to 3 EEGs a year just to monitor. Would you say that the lack of control, the emotional breakdowns, all of that would be more likely contributed then to his intellectual disability since the seizures are well controlled, or because there's still abnormal brain activity, it could still be leaning towards the epilepsy, or both?
It could be both. So most likely related to the intellectual disability. But as Russ said, you can see residual cognitive deficits even after the seizures are well controlled.
Okay, thank you.
I think that's, again, an important point, that if someone maybe has multiple disabilities and maybe has one that they consider more of their primary disability, like an intellectual disability or autism or something else, and then maybe considers the epilepsy or the seizures as secondary, it's still important to consider both conditions separately, because both can contribute to that, and every little bit helps in terms of getting improvements in cognitive function and mood and behavior and things like that. So have maybe time for one more question.
I have a question.
Yep.
My name is Kim, and I have a 18-year-old who is 1 year into his juvenile myoclonic epilepsy diagnosis. Fortunately, he had his first seizure in the doctor's office, and doctor was able to quickly diagnose him because he was there getting his first EEG. But he's been on Keppra, probably 2.5 teaspoons a day every morning and at night, and he is now in college. With the intellectual, I can say he went from, once he was diagnosed to, an all-B honor roll student and, doing fabulous in college. But what we see is not so much on the intellectual side, but more on the emotional side. Can anyone speak to, kind of the withdrawalness, or maybe even, just not so jolly or social as what we see emotionally in him?
So the thing about that particular story that makes me wonder is, you said he's on Keppra currently?
Yeah.
Okay. Yeah, so Keppra is a wonderful seizure medication, but it is pretty well known to have the potential to cause some mood-related side effects. So if you're particularly noticing that, academically he's doing well, his seizures are under good control, but it just maybe seems to be his mood that's different, that may be a side effect of the medication. It's certainly possible. It's a consequence of the change in his brain as his epilepsy is manifested. But it would be worth having a discussion with whomever prescribed him the Keppra to see if maybe there was something that could be changed there, to see if you can, eliminate that variable anyway.
Yeah, no, thanks. We'll follow up. And it's not a bad mood swing. It's just more maybe just not as empathetic, right, as a normal teen, you would say. But then teens are teens. But yeah.
I see.
Okay, well,
That's a tough one, yeah.
Yeah. All right, so we are at our finishing time here, so I really want to thank everyone for participating today. We had a great turnout today, so thank you everyone for joining us. And again, thank you, Dr. Tank and Dr. Johnson, for an excellent discussion. Our next session, November, we actually don't have a Learn and Share conference call because we want everyone to come to the Wellness and Epilepsy Conference on November 9th. Just to give you a heads up, our early bird special pricing ends on October 9th, so if you haven't registered yet, you can register for half off the registration fee if you register by October 9th. And then in December 4th, we have a Learn and Share conference call on medication side effects with Maisa Basha, who's an epileptologist at DMC Harper University Hospital. So I encourage you to join that as well. And if anyone has any questions about this topic or about anything epilepsy related, certainly give us a call at 1-800-377-6226 or visit our website at epilepsymichigan.org. So thanks again, Dr. Tank and Dr. Johnson, and thank you everyone for joining us.
Thank you.
Thank you.